Dr. Sharon Kohler. She's also a member of our board and has been with us for quite a number of years. Sharon, she is a professor at NYIT, and she's also a breast surgeon. And so she's going to talk to us a little bit about the management of individuals who are hospitalized with breast cancer.
Good morning, everybody.
Good morning. Good morning.
I'm very happy to be here. Thank you for inviting me again. It's always such an honor to be able to speak to our group here. I see a lot of familiar faces, and I'm so happy that this is going to be shared with the folks in Ghana as well, because the information is so important. And it's kind of like my lectures at NYIT where I teach. I teach there about 1 day a week, and I lecture quite often, and I'll just have a handful of students, while the rest of them, about 430, are sitting at home streaming the lectures on their computers. So this is, this is kind of what I'm used to. So I'm just going to imagine there are about 1,000 of you out there. So I was asked to speak about breast cancer and the hospitalized patient, and it's really not so different than breast cancer just in general, because I try my very best to keep my patients out of the hospital. Because of these nosocomial infections, we realize that the hospital really is not the best place for all patients, especially patients with any sort of immunocompromised state. So I think I'm going to be able to tie it all together soon. Yes, go ahead. This one, the next slide just tells you a little bit about me. I'm a fellowship trained breast surgeon. That's my specialty. But I'm also a general surgeon, so I do have a lot of knowledge about basically anything surgically related, and certainly infections are there. And then the next slide just has a picture of where I practice, and then we can go to the introduction. So this is what I was planning to speak about today. Little epidemiology just to start, just start a dialogue about the topic, and then some myths, because I hate hearing patients come in with a particular myth or a particular belief that is not true, because it's so important that we get past those so that we can start treating as early as possible, because most women with breast cancer are cured, and that is my goal. So some of these myths kind of stand in the way between a disease and the cure. And then genetics, which is something that's really up and coming every day. It seems to change. So I thought that I definitely want to touch on this again for all of you that I've spoken to before. Genetics keeps changing every year, so that was something I'd bring out. And even screening is changing. People are recommending different screening programs, and it must be very confusing when one group is telling you to do one thing and another group is telling you to do something else. So I'll try to tie it all together and give you my opinion, because that's the correct opinion, of course. And then diagnosis. How do you make a diagnosis so that if you ever happen to be in the position where you have to undergo one of these tests, I don't want you to be afraid or be confused about what they're asking you to do. It should be a good idea to just understand how the diagnosis is made. And just in general treatment, because everyone's treatment, which I'll explain later, is going to be individualized. And then, of course, the favorite part, the quiz. Okay, and then I'll be here for some questions. Okay, so next slide. Okay, so for 2018, I got all the stats up to date. This is a huge number of women, about 266,000 women just in the United States are estimated to be diagnosed with breast cancer in 1 year, and that's invasive breast cancer. About 64,000 cases of like the pre-invasive cancer. We keep trying to rename it because it scares people, but it is a pre-cancer that is basically the same as a cancer, except the cells are limited to the duct where they originated, which means that they haven't spread yet. So that's a lot of women too. If you notice, still it says 40,000, about 41,000 women will die from breast cancer. That is a much smaller number than the number of women that are being diagnosed each year. And so what that means to me is, by far, the majority of women are being treated and cured. Because if everybody who got breast cancer died, the numbers would be pretty much equal. But they don't. We cure most of the women we see. So next slide, please. It is the most common cancer, besides skin cancer, in women, and it is the second leading cause of cancer death. So we definitely want to take this very seriously and make sure that we're doing everything we can to prevent it. There's a lifetime risk of 1 in 8, and that's just for the average woman, 1 in 35 of dying. And there are 3.1 million breast cancer survivors. I updated this slide from 2 years ago. The number was like 2.5. It's amazing how many women are being diagnosed, but it's even more amazing of how many women are surviving. So, you know, we're definitely heading in the right direction. Okay, how do I prevent? This is the biggest question, and I think, yes, thank you. Okay, so how can I prevent breast cancer? Okay, this is huge because the answer to this question can also prevent a whole lot of other things, including nosocomial infections, which we're talking about today. If any of you, Dr. Reese was very clear about, when you get into the hospital and you are immunocompromised, you're heavy, you smoke, you are not exercising, you don't take care of yourself, and then you're in the hospital for some particular reason, you may very well develop an infection from being in the hospital. That's what a nosocomial infection is. It's basically an infection whose organisms are living in the hospital. These are bacteria that have colonized different pieces of equipment. They may be in little corners of the room that don't get cleaned. They may be in ventilators. We don't know, because if we knew exactly where they were, there would be no such thing. But hospitals go to great lengths to try to eliminate them from their environment, but it's clearly impossible because they still exist. And then you might say to yourself, well, how come all the people that work there don't get sick? I still work in a hospital a couple of days a week. I used to live in the hospital when I was a resident. I slept there every third night. How come I never came home with a nosocomial infection? Well, my immune system wasn't compromised. I wasn't overweight. I wasn't smoking. I was exercising because basically I was working. So that was my exercise. So that's why I didn't come home with one of these infections. So the key to maintaining your health and also decreasing your risk for a number of things, including breast cancer, are keeping yourself in a healthy state, which includes your weight. So there are lots of ways to reduce weight. Some of them work and some of them don't, and some of them work and then you gain it back. Anybody ever try to lose weight? Everybody. Anybody lose it and then have it come back?
Yeah.
So, I mean, if you want, when I'm all done, we can talk about that, because that's been my mission personally for the last couple of years, and I've been working real hard the last couple of months on some new techniques to try to lose weight. But that in itself will reduce your risk for breast cancer, because if you are postmenopausal and you have extra adipose fat on your body, it produces estrogen, and that increases your risk for breast cancer. So, in addition to everything else, maintaining a healthy weight is very, very important. May be very difficult, and like I said, we can talk about that too. a couple of years ago, I gave a little discussion about nutrition, and I still enjoy talking about that subject. Okay, vitamin D. A lot of people are deficient in vitamin D, especially in the winter months, so make sure your primary care physician is keeping an eye on that and keeping you up to up to a normal level. If you have to take supplements, then make sure you do that. We are still unclear about whether soy prevents or promotes breast cancer, so I say just eat it in moderation. And limit alcohol. Alcohol is fine in moderation again. If you overindulge, obviously it doesn't lead to proper nutrition and it can increase your risk for lots of diseases. And exercise, again, lead a healthy lifestyle. Choose to breastfeed if you are having children. Can you hear me? Am I having... You want me to talk a little louder? I'm sorry. Okay. So if you do choose to breastfeed, try to breastfeed because it is healthier for the mom, and it's also healthier for the baby. So breastfeeding will help to prevent breast cancer. Hormone replacement therapy is used by a lot of women. We don't like what happens to our bodies after our hormones start to drop. And that unfortunately also increases your risk for breast cancer because adding that extra estrogen, again, a risk factor. So try, if you need hormone replacement therapy for different types of reasons, which lots of women do, try using things that are more local instead of pills. Like putting like a cream instead of taking something that spreads through your whole body. And then environmental pollution can obviously increase your risk for everything. So here are some of my myths. The next slide, perfect. Have you ever heard this? A poor-fitting bra can cause breast cancer?
No.
I have. Well, I have women coming in, and every once in a while, is this because of my bra? They'll like feel a lump, and they'll say, I think it's because my bra didn't fit right or something. So if you feel a lump, it's not your bra. Still can't hear me. Okay. I can't get breast cancer because no one in my family has cancer. That is definitely not true. I've heard it taught time and time again. Yes, women with a family history have a higher risk, but even someone who has a completely clean history, no one ever in their family had breast cancer, they are still at risk. And I don't know the reason for this, but I'm going to suspect that it has something to do with our society. We are exposed to different things than our ancestors were. Foods are now processed and evil, if we want to talk about diet. But the foods, they are using this high fructose corn syrup. They're using all kinds of refined wheats and different grains. And we're different people. So even though people that lived before us never had the problem, it doesn't completely eliminate the risk for us. So, okay, all lumps of breast cancer. This is another big myth because they are often afraid to come see me because they think that I'm going to tell them they have cancer. They're usually not cancer. There are lots of lumps that occur in a woman's breast that are not cancer. Most of them, in fact, are not cancer. So if you feel a lump or if you see something,
Say something.
excellent, say something. That's for the New York folks here. That's our subway slogan. If you see something, say something. Okay. Okay, if I'm diagnosed with breast cancer, I will die from the disease. Again, I already mentioned, definitely a big time myth. Most people are cured, especially when we find the cancer early. Okay. Next slide, please. So, what is my risk? So how can you, what things would decrease your risk? Being older when you had your first menstrual period, so it's the age of menarche. If your age was older, say 14 or 15, that's less years of hormones, of estrogens, so that is statistically something that would lower your risk. Same with menopause, if you started menopause earlier. Again, fewer hormones, it's all hormone related, to be honest with you. That's the one thing we've been able to conclude, that even though these hormones are good for some parts of the body, the more that the breast tissue is stimulated, the more risk that your cells could develop a cancer. Getting regular exercise and maintaining a healthy weight, those are things that are under your control. How many children you have may or may not be under your control, and also some of these other things. So, now, another thing that will increase your risk would be hormone replacement therapy. So please do not choose this unless it's absolutely necessary. It's all a risk versus a benefit type of decision you should make. If you have a personal history of breast cancer, or you've had some high-risk lesions, then your risk for breast cancer is going to be higher. And family history of breast cancer, even on your dad's side of the family, that increases your risk, in addition to ovarian cancers on either side of the family. There's radiation therapy to the breast and the chest. There used to be something called mantle therapy for Hodgkin's disease, and I don't think I've seen a patient who's developed breast cancer from this, but it was always in the textbooks. So I realized that, fairly not that recently, the radiation oncologist stopped performing this particular type of therapy in the United States, until my very good friend, her husband, developed not breast cancer, but very terrible cardiovascular disease from his treatment. He was treated in Italy. So I always keep this up here because there are a lot of people that are from other countries and may have had treatment in other places, parts of the world, where this is still being practiced. So the chest therapy.
Dr. Cola,
yes.
Can you speak a little louder? What you're saying is so important.
Okay, I will try. It's hard. Drinking alcohol is under your control for most people. So keep limiting it to a couple of times a week, or 1 or 2 drinks at a time would be advisable. You don't have to give it up completely, just moderation. And then night shift work. Now that's an interesting thing. People who work nights have some significant risks. I'm not completely sure how this works out mechanistically. May have something to do with cortisol levels. I know that there are hormonal shifts day and night that occur, and cortisol is released in the night. Maybe if you happen to shift that and be up when you're supposed to be resting, it could increase your risk. I know it does affect cardiovascular health, this too. Perhaps we have even more of an expert can go over that. So now we have our relative risks. So the biggest risk is genetics. That's what the BRCA mutation is. That would be the mutation in one of 2 genes that increases your risk for both breast and ovarian cancer and some other cancers. We have other genes now that are being tested, but that relative risk is a little bit lower. I didn't include them on this slide. Now the chest wall radiation, that's what I was referring to before, for the treatment of different types of bone cancers and hematologic diseases. The increased breast density. New York State is now required to report, the radiologists are required to put on the report whether or not you have increased breast density on your mammograms. Have any of you seen that? Well, not just on the report, but even the report they send to you. They send you a report in layman's terms, or simpler terminology, so that it's clear what they want you to do. And they will put a little sentence there about increased breast density. And I'm not so sure it is clear what they want you to do when they put that there, but they have been required to do so. Has anyone seen that on a report? Have you guys had mammograms?
Yeah.
Yeah? Okay.
Okay, just making sure. So it's usually written on it, but that's a fairly new thing. You may not have noticed. Yeah.
At what age should you stop getting them?
Ooh, that's a good question. I'm going to get to screening very soon, but the question was, what age do you stop getting mammograms? And that entirely depends on who you speak with, because that is a very controversial topic. I can say my opinion, and I'll just give you my opinion, which is always right. And then I'll talk about what other groups have recommended. My opinion is you get mammograms once a year until you are no longer in good health. If you are in poor health, maybe in a nursing home, have Alzheimer's and not really communicating well, like if you know that you're really not going to be around more than 3 or 4 years, absolutely, you don't need a mammogram. You know, a mammogram is supposed to find a cancer before it causes you any harm. If you think you're going to pass away, if you've got a sick patient and you think they're not going to do well, then you really don't have to continue doing mammograms. But if you are 99 years old in wonderful health, and living independently and walking and feeling great, absolutely, because the treatment of a cancer that can be detected on mammography, like a precancerous lesion, is a simple little outpatient excision. You can even forget the radiation therapy and be on your way and never have to worry about it again. So I think that for someone who may be 78, because some organizations say stop checking at 75. If at 78 you develop an invasive cancer and they tell you need chemotherapy, that would be shameful. If at 76 you could have just had it removed and you'd be done. So that's why I do not follow the recommendations that I've seen from a couple of groups that a lot of people respect. So that's my opinion. So there's no answer to your question. Okay, so we mentioned family history, early menarche, hormone replacement therapy. Like I said, it's down here, but it's a small risk. It's only 1.3. So it's a risk versus benefit ratio. If you just need to use the hormone replacement therapy for a year or two to get yourself over the hump of these hormonal changes that are making you miserable, then if you have to, okay, just keep in mind that it does increase your risk. If you plan on taking the hormone replacement therapy until you're 95 years old, probably not a good idea. And then the late menopause, which also small relative risk. So the genetic evaluation is a big question that I often get, because people with a family history always want to know, well, should I have that genetic test? It's advertised now. There's a company called 23andMe. You can order it on Amazon and send them a little swab or a spit or something into their tube, and they will tell you what sort of risk you have. Well, this is a little bit more precise. We try to test people that are are more likely to be positive. We don't just test everybody. And the reason for that is that the insurance companies won't pay. So we can only test the people with a certain amount of risk. They have guidelines. Otherwise, the cost would be very expensive, and people don't want. In fact, I don't understand why, if somebody wants the test, they can't have it, except for the cost. So who absolutely needs to be tested? Those, or at least to be have their history evaluated by a genetic counselor. And that would be somebody who's had breast cancer at a young age, 2 cancers at one time, especially if it's on 2 different breasts. If there's early cancer in the family, a man can get breast cancer, and they're more likely to have a genetic link. So if there was male cancer in the family, people with a personal history of ovarian cancer, they are linked. And then Jewish heritage, especially the Ashkenazi Jewish heritage. And then if there was a mutation known in the family, all the rest of the family members should be tested for that mutation. If you have breast cancer and it's something called triple negative, so that's a particular type of breast cancer, even if you're older and you have the cancer, but if it has all the hormone receptors are negative, that's well estrogen, progesterone, and then the HER2 receptor, if they're negative, then we test those patients. And then even pancreatic cancer, if you see that plus another cancer in the family, you would want to test that patient as well. So here we go. The next slide deals with our confusion. And I've had this slide in my presentations to the medical students, to community groups, everyone, for the last like 13 years since I started talking about breast cancer, and it doesn't change. There is a continual confusion and controversy around mammography. There are so many people that have tried time and time again to prove that mammograms are harmful, that by taking a woman and having her breast radiated once a year can actually cause breast cancer. No one has ever been able to prove this. In fact, the amount of radiation in a mammogram is very small. You know, some people have lumps normally. They've had them their whole lives because we have this lumpy breast, some people. So that's why getting to know your own breast is so important. Okay, if you have a lump and you felt that lump for the last 25 years and it has not changed, do you think that lump is a cancerous lump? No, it's not. We're always looking for change. So any change, that's what we should be concerned about. Okay, so the most common symptom of breast cancer is a new lump. And that's like we call that a symptom, as opposed to a sign, which is something that we'd find on the mammogram. So the most common symptom, thing that you would find yourselves, would be that lump. It's typically irregular, so if you feel something very smooth, that could just be a cyst. Cyst is filled with fluid. It could be a fibroadenoma, which is a benign lump. But a cancer typically is irregular, and it kind of fixes itself. It doesn't want to slide around. And can be tender, but they're usually not painful. But just because something's painful, we don't eliminate that cancer from the differential, but it could. Usually it's not. Okay, this is a little bit of a repeat. And the next slide, I mentioned that cancer can be spread to the lymph nodes under the arm, so also check there, because sometimes people will actually have a swollen lymph node and there won't be anything in the breast that can be found. So even just a swollen lymph node, even though the breasts seem okay, that's something to look up. Even if your mammogram, this is another myth. My mammogram was fine, so I'm not worried about this lump. Not true. You know, if you have a mammogram and it's abnormal, fine. But if you have a normal mammogram and you feel a lump, there can still be a cancer there. Our imaging is not perfect. Okay, so if there is a change, anything that concerns you, don't just assume because your mammogram was okay that you're good for a year.
Yeah, you can.
Yes?
You can also have a mammogram that's normal and you don't palpate any lumps in your breast, and it still can be positive.
Oh, absolutely, yes. Yes, you can have a cancer even with a normal mammogram, normal clinical exam. Not every cancer is found on our screening. Well, most of them are, but we do unfortunately find some women who have, usually it's a lobular cancer as opposed to a ductal cancer. They tend to spread a little more plate-like, a little more, they're a little more invasive, which means they don't form as much of a lump that can be seen. So sometimes they just show up as just a little asymmetry. Those cancers, if women have their imaging done at the same facility every year, are more likely to be found. if you go to different facilities, they'll miss it, because if they can't compare the images from one year to the next, it may look completely benign, but because it was different from last year's, they'll see it. But if you go to a different facility, then they may not see your cancer. I'm not telling you to never change imagers. I'm saying if you do need to change your facility for insurance reasons, maybe you don't like the one you've been going to, get copies of your pictures and bring them with you. They have to compare them. Okay. So, how is cancer diagnosed? It's diagnosed by a clinical breast exam. We get the suspicion if we feel something that doesn't feel the same as the other breast. And then you'll get a diagnostic mammogram as opposed to a screening mammogram. There's usually an extra view, and they will complete the exam while you're there. If they need to do compression, spot compression views, or if there's calcifications that need to be magnified, they'll do it all at the same time rather than send you a letter and tell you to come back 3 weeks later. The breast ultrasound is for almost any time there's dense breasts, or if there's a lesion in the mammogram that's particularly worrisome. And then MRI. That is a really great screening tool for women at high risk. So if your sister had breast cancer, your mom had breast cancer, or you have one of those precancerous lesions that's removed, and now you're back for screening, sometimes we'll include MRI in screening. And then there are different types of biopsies. Fine needle aspiration, and then core, so that's a different size needle, and then excisional and incisional or surgical biopsies. So the next slide shows the screening mammogram. And this, if there are any men watching this, this is kind of why women don't like to go for mammograms. You have to place your breast in between two hard plates. And while you hold your breath, somebody squeezes those plates even harder and tells you not to breathe, but you can't breathe anyway. So that would be why women don't really look forward to the day. I had a patient, I will always remember her. Her birthday, she went every year on her birthday for her mammogram. That was her birthday present to herself. Like, okay, I could think of better ways to spend the birthday. But that was her thing. Her birthday, made sure she was healthy, and that was always a good present to have the radiologist say you're fine. And then if you have an issue, then they're going to ask you to do some of the additional studies. Some things that they can see, if you look, these are, this is a picture of a mammogram with fairly subtle findings. If you had the two next to each other, you can see that there's some asymmetry, but you don't really, you wouldn't necessarily notice that if you didn't have the two there, right next to each other. So a lot of times you're just comparing the two breasts. You want to see if the patient has something similar on both sides, because then it's less likely to be a problem. But certain things that you're going to be concerned about are nodules, spiculated masses, those are irregular, and asymmetries. The 3D mammograms, have a lot of your facilities converted to 3D? Okay. Most people now, most facilities now here in New York are using 3D mammography. Insurance companies don't pay extra for it, so some facilities are charging you a little extra. Some are just charging the regular price and not trying to charge the patient any more. But the 3D mammogram is really a good test for younger women with dense breasts. It is proven to be superior to the standard 2D digital mammography. And the 3D mammogram, if it's done with a certain type of program, can reconstruct the regular 2D images, so they don't have to do the 2 extra images. So some of the newer machines can even perform a 3D mammogram without any extra radiation. Some of the machines that came out in the first generation of 3D mammograms do extra shots, so it's a slight increase in radiation dose, but not so much to make it detrimental because studies have proven that women are called back less. They're called and told to come in to do more testing, much less when they have a 3D mammogram as opposed to the traditional mammogram. The traditional mammogram has been proven to be equally effective in diagnosing cancers in women that have average densities in their breasts. So if you're still using that, it's not bad. But we do have a newer tool that you're certainly hearing about. Okay, and then I put the question for improved sensitivity because it's really only improved in certain women, but it is what most of the facilities are switching to. So the next slide shows a picture of a cancer. And you can see this is actually the same patient with a regular mammogram and a 3D mammogram. And you can see that makes it easier for the radiologist to see. And the next slide explains what breast density is all about. This is actually a diagram of 4 different women with different densities of breast. And because increased breast density has become such a high-risk lesion that was barely mentioned before, that it became, a real issue. And now the radiologists are required to let the doctors and the patients know. And what I do is I will always order an ultrasound, and if the patient has this plus some sort of family history, I might even order an MRI as well, because you can see that a cancer could easily be hiding in that dense tissue. And not only could it make it less accurate, the fact that you have dense tissue puts you at higher risk. So this is this is another picture of kind of the same idea. And then the next slide talks about ultrasound. Ultrasound is good because if you have a very dense area, they can look within that specific area and see if there may be something hiding that's more dense than the surrounding tissue. Ultrasound is looking at tissue density. So when they put the probe on top of an area, they'll look to see if there's a different density. And that's what this is. The dark area is an irregular space that contains tissue that's more dense than the surrounding tissue. That's why it's dark, and the sound waves aren't passing through it. So it makes it fairly easy for a doctor to see that there's something hiding within that dense breast tissue. Ultrasound is great, except it's not a good screening tool, because if you've ever had one, you know that the technician puts the jelly on and she can either go fast or slow. She can, depending on how you use it and your skill as a technician, the test is either, diagnostic or not. So we don't use it for screening because there's no way to standardize it. The next slide shows the MRI, and that is becoming much more popular to use now. More radiologists are becoming accustomed to reading them, and the original problem with MRI, which is an inordinate number of suspicious lesions requiring biopsy, is not happening as much anymore. So MRI is a great test. There are indications for MRI besides screening high-risk patients, like if you have implants, you need to look behind the implant. But the MRI mainly is here for our high-risk patients. MRI is different from the other tests because it uses a dye that is metabolized by cells. So you're not simply looking at the density of the tissue, you're looking at how quickly the tissue utilizes glucose. So, or like a food substitute that's injected into the patient. So it's looking at function as opposed to the density of the tissue. Just a little quick definition of the types of cancers you may have heard. And I include this because if you know anybody with, does anybody know anyone with breast cancer? I can almost guarantee you that almost everyone has their hands up, and almost everyone's cancer is different. Okay, because people are treated based on their very specific tumor type and the characteristics of each tumor. So these are a few of the types of cancers that there are. I'm showing you a picture of inflammatory breast cancer next. So the next slide, please. I'm showing you that because I don't want anyone to ever think that inflammatory breast cancer is an infection for more than 2 weeks. Everyone assumes that something that looks like this is an infection, even your doctor will. But that doctor should very well give you some antibiotics and tell you to come back and make sure that it has gone away. If it doesn't, if it's not completely eliminated with a course of antibiotics, you need a biopsy, because an inflammatory breast cancer is not an infection. It just looks exactly like one. So the next slide, okay, what are your treatments? And I just thought this was a cute picture because everyone's treatment's different. It's a rainbow of treatments, so it's individualized for each patient. What types of things might you have? So far, I haven't actually mentioned anything that happens to you in the hospital. Okay, so far, all your screening, all your biopsies, all that, you are free from nosocomial infections. But when you have your surgical treatment, that's when you may find yourself in the hospital, especially if you have a mastectomy. Usually the lumpectomies, where you just remove the cancer and leave the rest of the breast, those patients typically go home that afternoon. It's just a same-day type of surgery. The lumpectomy conserves the breast, so it's usually given with radiation. Radiation, again, not in the hospital. But a mastectomy, where you remove the entire breast, women will stay at least 1 day. And depending on reconstruction, if you have a significant type of reconstructive process, like a flap coming from one part of the body to the breast, those patients might be in the hospital for 4 or 5 days, in which case maintaining optimal health and not entering the hospital in a compromised state will definitely decrease your risk from complications. The sentinel lymph node biopsy and the axillary lymph node dissection, they are how we evaluate the armpit, and that, as I mentioned, is where cancer from the breast typically will spread to first. So we used to always just remove every single node from the armpit that we could find. Women develop very swollen arms from lymphedema. Now, we hardly ever remove all the nodes. We do a sentinel lymph node biopsy. Even with a couple of positive nodes, we have so much data to show that the radiation can just be directed into the armpit, and you may not even have to go back and remove all the nodes with some positive nodes there. So depending on the cancer that you have and the extent of the nodal involvement, you may even be able to eliminate that. We're doing less and less surgery these days, so keeping more and more women out of the hospitals. Okay, and then the radiation therapy comes in a couple of versions. The partial breast, where you radiate just a small portion, that's a quicker type of treatment. But the whole breast that I was just mentioning, that may include the armpit, that's like a 6-week course of radiation. And it's like a once-a-day thing, not on weekends or holidays, because cancer does not grow on weekends or holidays. But it's once a day. It's like getting an X-ray. So you go to the facility, you lay down on the table, you hear like the machine buzz, and then they tell you you're done. It's not a terrible thing. You can still work while you're doing that. So. Okay, so now the next slide shows the systemic therapy. We've got chemotherapy. That's what you've all heard about and have all been afraid of, because you see people with, with hair loss who are vomiting. You expect, the worst. And it's not like that anymore sometimes, but most of the time we have medications now that can counteract some of those side effects. Not the hair loss, unfortunately, but the vomiting, the low blood counts, things like that. Then there's hormonal therapy, which doesn't have the same type of side effects, much easier to to tolerate and very effective. And we also have, and hormonal therapy here is a different type than hormone replacement therapy. Totally different medication. And then the targeted immunotherapy also, those are really big now. They are fewer side effects, targeting each individual cancer. So they're very new, and they're becoming incredibly popular because as women are developing cancers, we're testing the genetic profile of each tumor and treating specifically to that. So that's why you can't compare with your neighbor or in your support group anymore. We're not just taking the whole breast, taking all those lymph nodes and hoping for the best. Or we're hoping for the best anymore. A little slip of the tongue. Now we are targeting specific types of tumors to specific medications, and we are very successful. So I hope no one's afraid of what they might find, and they will get diagnosed and treated early. So I will start with my questions. True or false, I cannot get breast cancer because no one in my family has ever had breast cancer. Okay, let's see, is it false? Okay. False. False, yes. Okay, next question, true or false? Okay, so next one. Okay, true or false, all lumps in the breast are cancer? False. False. Next one, true or false, everyone with breast cancer gets essentially the same treatment? False. False. Okay, true or false, most people diagnosed with breast cancer eventually die from the disease? False. False. Yes, I'm hearing. Everyone's getting the questions right. Excellent. And okay, here's a tough one. What is the average woman's lifetime risk of breast cancer?
1 in 8.
Excellent. They're paying attention. Okay, 1 in 8 is correct. So does anybody have any questions for me? Yes.
So if you get the genetic mutation testing and determine that you have the gene and that you're high risk of breast cancer but you don't have it yet, is there other things that you can do besides diet and exercise, like some kind of medical treatment that you can
Yes.
implement?
Okay, so if you want to prevent breast cancer, you can take hormone like a tamoxifen that can reduce your risk, or raloxifene has less studied but also is known to reduce risk, so that's chemo prevention. The other thing you can do is remove your ovaries. When you're done having children, let's say the woman knows, she's a maybe Ashkenazi heritage, a lot of members of her family have been tested and they're positive, so she checks when she's 21, oh my goodness, I have the gene. She may choose to have her children earlier than some of us working women that choose to have children later. And then at, maybe in her early 30s, she removes her ovaries because it's the estrogen from the ovaries that can increase her risk. So that also decreases risk. What else would she do? She would increase her surveillance, certainly use MRI and mammograms starting at a younger age. And she may, at some point, choose prophylactic surgery to remove the breast tissue as well. And that could reduce her risk by as much as 90 to 95%. Never to 0, but it still would be helpful. That woman, too, for some of these genes, have risks of other cancers, such as ovarian cancer, if it's BRCA1 and 2. That's an even tougher thing because ovarian cancer has very little screening to find it at an early stage. Not stage. So the stage, even when we screen for ovarian cancer, if we screen positive, we often are finding it at a later stage. So, and there have been studies showing that these women who have removed their ovaries to prevent their breast cancer, like 15%, I think, had early ovarian cancers that were not known. They were screened. They had ultrasounds and all the blood levels and everything. They were fine, and they just happened to find them there. So this genetic mutation is no joke. You can screen for breast cancer pretty effectively, not for ovarian. Any other questions?
Yeah.
Oh, lots of questions.
My daughter passed
passed away with breast cancer
I'm
at
sorry.
48. As far as the relative, we said there was nobody in the family that had breast cancer. However, I just realized my husband, he was in the Navy, and after 40 years, he developed mesothelioma. And I'm wondering now that because of that cancer, did that have anything to do with my daughter not dying?
Well, the question is mesothelioma related to breast cancer? And I would say no, not that we're aware of. Mesothelioma is very much related to asbestos and smoking, and asbestos in particular. So if he was exposed to, and a lot of men during World War II were exposed to asbestos. So that's more of an environmental cause. Where the breast cancer at 48, if she passed away at 48,
She passed away at 48.
she may have actually
she
had the
started
cancer
at
for a couple of
38.
30. So that's a very young age.
Yeah,
And
yeah.
and I don't know if she was tested for any sort of mutation, and even if she was, it may not mean that much now because every year we add more genes to the panels. So if you were tested 5 years ago, talk to a genetic counselor. You may need to be retested. Yeah, the test keeps changing and adding more mutations.
Cancer and the environment. A lot of my children's friends who lived in the same area, at least 5 of them have passed away in the past, say, 5 years. And we are wondering because now as we go back, we realize they used to play in an area that we now found out was a dump.
Oh my goodness.
So we're questioning, could that be because the cancer because of that?
So you're saying that 5 people had breast cancer,
I
and
don't
they all
know
played in the same
I don't know exactly what kind of cancer they have.
You know what? I don't want to say anything. I have no idea. Look at the people that were exposed to the carcinogens at the World Trade Center and the cancers that they are getting. They're getting lymphomas, they're getting lung cancers. That's a similar kind of thing. You're talking a dump. You know, what difference is that than the buildings that collapsed? Whatever is in the air, was in the air down there, it's clearly making people very sick. So I'm sure some similar environmental toxin could have been around too. Who knows? I don't know.
And one more question. A lot of these young people are now taking drugs. I can't remember the name. I know it starts with a C, that it's legal in California, but it's not legal in the United States. It's not marijuana, it's cannabis.
That's marijuana. That's a marijuana.
Are you asking me about cannabis? Is it good or bad? I think marijuana is not a good thing. I think personally that it has some beneficial properties for certain patients, you know, cancer patients, maybe some chronic pain. And that's only if it's taken in like pill or oil. Like they make butters, they make chips with it, and you know, for someone who's undergoing chemotherapy and is losing weight because they can't keep anything down or they're not hungry, and this is, as you know, helps with appetite, helps with sleep, fine. And they need to do more studies to see exactly what the indication should be. But it's gotten a little too popular in my opinion. I think it doesn't really lead to necessarily good choices. And definitely if you smoke it, it's bad for you. Okay.
I noticed that there are a lot of young kids, young girls developing real early. I'm talking about like 8, 9, 10 years old. And some of them are getting their periods at 9 and 10. So would that have any effect to in their later years?
Yes.
Developing
Yes, so the
cancer?
early menarche is a risk for breast cancer. So you see a trend of women beginning menses earlier and earlier these days.
Yeah,
I don't know why that's happening. Maybe they're putting hormones in the food. Maybe they're not in the food, but giving it to the animals that people are eating. our society, what we're doing to our foods, are definitely changing our diseases. Yeah. So yes, it's not a good thing, and we may be causing it ourselves. Who knows? Yeah.
I have a question. I've seen on the TV the medication Ibrance. It's for like hormone receptor cancers, and then there was Herceptin too. Is that, I know Herceptin is not for the hormonal, but the Ibrance is for hormonal cancers, like estrogen receptor cancers.
Mm-hmm.
My question is, well, I guess I answered my own question.
Okay.
Okay.
Okay, so I was asked about a cap to prevent hair loss during chemotherapy. I have not heard of it. I know that sometimes if you cool down the tissue, less there'll be cause vasoconstriction, less blood flow with the chemotherapy agent in it will travel to that particular area. That's why they give people ice pops so that they don't develop ulcers in the mouth. Probably this cap is something that cools down the scalp. I have not seen it effective in this country. I don't do chemo. I'm not a medical oncologist. I just do the surgery, but I'm pretty sure they're not using it. Perhaps it's not as effective as we would like it to be. Any other questions?
And not every chemotherapeutic agent takes out your hair.
Yes, they don't all. Some do, some don't. Yes.
People that have the BRCA gene, do they still, some people want to have their breast removed, is that drastic?
If you have a genetic mutation that gives you a 60 to 85% cancer risk, removing your breasts I don't consider drastic.
Yeah.
Do not. You should, eventually. Maybe not at 20. The risk starts maybe at 30, so you start checking, and if you see some suspicious lesions, don't wait until you have an invasive cancer. Same holds true for the patients with the mutation. You want to find the cancer early or prevent it. You don't want the patient to wind up with an invasive cancer. Even if you can cure it, you'd rather not have to go through that. So it's better to remove it when you can schedule it, when it's a good time in your life, when you can take a couple of weeks off from work, not as an emergency. Plan your reconstruction to, with the, exactly what you want. You don't want to wait until you're 45 or 50 and then, oh, there's this horrible cancer here, now I'm going to remove the breast. So I do encourage women to make sure they're emotionally and physically and everything ready to remove it. But if they're at high risk, something around a 50-50 chance, I will help encourage them to do it, because I'd rather see prevention than what could be the outcome. Is that, any more questions? Are we good? Okay. Well, thank you, everybody.
Thank you.